Good evening, everyone. Welcome to Biomarkers Self-Talk presentation. For today's session, Ish Karnani is our presenter, and he will be discussing on the topic predicting post-operative gastric cancer prognosis based on inflammatory factors and machine learning technology. Yash Karnani is currently working as a junior research intern at Renix Life Sciences, exploring clinical applications of wearable devices and extracting information from medicine strips for potential use in health monitoring and medical diagnostics. He is currently pursuing his BTech in computer science and IoT at Geetham University, and his academic background includes artificial intelligence, IoT, and data science with projects in computer vision and web development, as well as an internship as a Java developer at Woodpecker Analytics. His experience at Renix helped him strengthen his expertise in AI and data analytics, which enables him to contribute to innovative healthcare solutions. He aspires to leverage technology to drive impactful advancement in data driven decision making. Now, I welcome Yash to start with the presentation.
Thank you, Uma. Good evening, everyone. I am Yash Kanani from Renix Life Sciences. Today, I'll be presenting a study titled Predicting Post-Operative Gastric Cancer Prognosis Based on Inflammatory Factors and Machine Learning Technology. This study focuses on how we can use machine learning to predict mortality in gastric cancer patients using simple, accessible inflammatory markers. Gastric cancer is the fifth most common cancer, and sadly, it's the third leading cause of cancer related deaths globally. One of the biggest challenges is that most patients are diagnosed at an advanced stage, which significantly reduces their chances of survival. Accurate prognosis prediction, especially after surgery, is essential to guide post surgical treatment plans, prioritize follow up, and potentially improve long term survival. Limitations. The current prognostic models like the TNM staging system have clear limitations. Patients with some TNM stage can have very different survival outcomes, which means we are missing critical predictors. Traditional models don't account for systemic factors like inflammation that may significantly influence prognosis. The TNM staging system provides a broad classification but doesn't capture the patient's immune response or biological behavior of the tumor. Imagine two patients, both with stage 2 gastric cancer. One might survive for years with no recurrence, while the other might relapse quickly. Why? Because factors beyond the tumor's physical size, like systemic inflammation, significantly influence patients' outcome. So, this study aims to bring those hidden biological markers into prognostic conversations. Inflammation and cancer, the missing link. Chronic inflammation plays a central role in the development and progression of many cancers, including gastric cancer. Tumors often trigger an inflammatory response that changes the balance of immune cells in the body. Two markers in particular, the Neutrophil-Lymphocyte Ratio, or the NLR, and the Platelet-Lymphocyte Ratio, or the PLR, are now widely recognized as reliable indicators of systemic inflammation. These markers are simple, cost effective, and can be calculated from routine blood tests. Neutrophils, when elevated, actually help the tumor grow by promoting angiogenesis, basically feeding the tumor with new blood cells. Low lymphocyte counts weaken the body's ability to fight off cancer cells. Platelets can also shield cancer cells from immune attacks and help them travel through the bloodstream. So, NLR and PLR are not just lab numbers, they reflect what's happening in cancer battlefield inside the body. Existing models. While TNM staging is most commonly used prognostic tool, it does not fully explain individual differences in survival outcomes. Inflammatory markers like NLR and PLR are not usually incorporated in these models. There is an urgent need for more comprehensive prediction tools that combine clinical, pathological, and biological factors. Traditionally, we have focused heavily on tumor centric features like how big is the tumor, how deep has it invaded, but this approach misses the host systemic response, especially when whether the patient's immune system is effectively responding to the tumor. Integrating simple blood markers with clinical staging could make predictions far more accurate and individualized. The promise of machine learning. Machine learning can capture complex, non-linear relationships that traditional statistical models may miss. ML has already proven successful in predicting outcomes in cancer like bladder, prostate, and breast cancer. Unlike conventional models, machine learning can detect hidden patterns in data and make predictions that are more personalized and more accurate. Study objective and design. The objective of the study was to develop a machine learning based model that uses both inflammatory markers and clinical features to predict mortality in gastric cancer patients after surgery. The secondary goal was to identify which factors are most predictive of survival. The dataset included is of 1056 patients from BioStudies database. Inclusion criteria: stage 1 to stage 3 gastric cancer with complete clinical and follow up records. Patients with other malignancies or incomplete lab results were excluded. Role of inflammatory markers in cancer. High NLR and PLR values have been consistently associated with worst outcomes in many cancers. Elevated neutrophils are known to promote tumor growth and suppress anti-tumor immunity, while low lymphocyte levels indicate a weakened immune defense. Platelets can also drive cancer progression by supporting tumor blood vessel formation or angiogenesis. Current evidence in other cancers. Research has confirmed that high NLR and PLR are linked to poor prognosis in lung, breast, prostate, and esophageal cancers. These markers have been proposed as complementary tools to existing staging systems. However, no established machine learning based models have combined these inflammatory markers for gastric cancer prognosis, making this study particularly novel. The features used for prediction. The model uses a mix of clinical and inflammatory features. Clinical features included age, gender, tumor size, TNM stage, and the histological grade. Inflammatory markers included NLR, PLR, and the COP-NLR, which combines platelet and neutrophil counts into a single score. All the blood tests were taken 1 week prior to surgery to ensure consistency. Here, we also have a correlation heat map which shows how these features relate to each other. Age remains an important factor, but it's fascinating to see that the inflammatory markers actually outperformed tumor size and even TNM stage in this study. The correlation heat map helps us visualize how features like NLR and PLR don't just exist independently, they interact and influence survival in ways we are now starting to understand. Machine learning pipeline. The study tested 6 machine learning models: logistic regression, precision tree, random forest, gradient boosting, GBM, and XGBoost. The dataset was split 70%, which is used for training, and 30%, which was used for testing. A five-fold cross-validation was applied to ensure that the models were not overfitted. Model performance was evaluated using accuracy, recall, F1 score, and the AUC. Each machine learning model has its strengths, like the random forest is great for handling feature interactions. Logistic regression provides clear interpretability, and gradient boosting models often shine in classification tasks. The fivefold cross validation means that the model was tested on different subsets of data to ensure it performs consistently, and it's not just one lucky split. AUC, or area under the curve, is a key metric here. It tells us how well the model distinguishes between survivors and non survivors. Model performance. So, in the training results, Random Forest achieved a highest accuracy in the training set with an impressive accuracy of 88.4% and an AUC of 0.943. XGBoost also performed well, but Random Forest was slightly better in terms of recall, which measures the ability to correctly identify true positive cases. Next, when tested on new unseen data, logistic regression actually outperformed other models in the test group, achieving an accuracy of 75.9% with an AUC of 0.840. The GBM model had the highest recall in the test set, which is important for minimizing false negatives. It is interesting that logistic regression outperformed random forest in the test set. This is likely because simpler models like logistic regression tend to generalize better, while more complex models like random forest can sometimes overfit to the training data. The future important rankings. The most influential predictors of mortality were NLR, PLR, patient age, followed by tumor size, TNM stage. It's important to note that NLR and PLR, simple, inexpensive blood markers, ranked higher than traditional clinical features. One of the most important takeaway from this is that the immune system response as captured by NLR and PLR may be more predictive of outcomes than the tumor size. Inflammatory markers are inexpensive and easy to mention and routinely available, which makes them highly scalable in clinical practice. Key finding and interpretations. This study demonstrates that inflammatory markers are stronger predictors of mortality than tumor size or even TNM staging. Machine learning models successfully capture the nonlinear effects of inflammation on patient survival. These models can provide actionable insights to clinicians, potentially guiding post surgery treatment plans. A comparison with the previous literature, our findings align well with research in breast, lung, and esophageal cancers that identified NLR and PLR as critical indicators. This study further demonstrates that machine learning provides a more nuanced, individualized risk prediction compared to traditional regression models. These study limitations. There are some limitations to this. First, the dataset is limited to East Asian population, which may not generalize to other regions. Secondly, this is a retrospective study, so prospective validation is needed. Lastly, there was a class imbalance between the survivors and the non-survivors, which could slightly bias the results. Conclusion. In conclusion, machine learning based models that incorporate inflammatory markers like NLR and PLR can accurately predict gastric cancer mortality after surgery. Random forest and logistic regression were the most effective models in the study. The simplicity and accessibility of NLR and PLR make them ideal candidates for clinical use. Let's discuss the clinical implications. Integrating these machine learning predictions into electronic medical records can provide real time risk assessments. These tools can help prioritize high risk patients for more aggressive follow up. Overall, this approach could significantly enhance personalized cancer care. Imagine a scenario where electronic health record alerts a doctor. This patient has high NLR and PLR. Consider closer monitoring or additional therapy. This is the direction where we are moving towards data driven and more real time clinical support. The future directions. This future research should focus on validating these models across diverse international datasets to confirm their global applicability. Real-time monitoring using mobile health platforms could further improve predictive accuracy. There is also an exciting potential to explore whether NLR and PLR can predict response to newer therapies like immunotherapy. Multi-center validation will also help ensure that model is robust among different ethnicities, dietary habits, and healthcare systems. Thank you for your attention. I'd be happy to answer any questions. You can reach me at yash@renix.org or connect with me on LinkedIn at the link provided.
Thank you, Yash, for the presentation. Audience, now the floor is open for the questions. If you have any queries, please type them in the chat box. Okay, I don't see any questions. Thank you, Yash, for the presentation, and I thank everyone for attending the session and hope to see you all in the next presentation.